Hi dear friends, very good evening to all of you and welcome to this Fmge 12th January recall pediatric session in which I'll be discussing the pediatric questions which have come in this Fmge January 2025 exam. We'll try to see what were the answers to those questions, although to be very frank, I could get only a few questions, and even in those questions, the options were a little debatable. Some students were saying that there were a certain group of options, while the others were saying that there were other options. Anyway, so based upon whatever we could get, the options and the questions, we'll try to answer to the best of our ability. And in case we at a later date get all the questions and with complete options, all four options for each question, we might have another session. It is still too early. We might have another session in which we'll be again discussing all those questions, because please be very clear about this, that in case the options will be different from what were actually asked in the exam, the answer will become different. So this is a disclaimer. Whatever I'm telling you, the answers is based upon the options that have been told to me. Some of the options are missing. So given the fact that all options are not there, and also given the fact that options may be debatable, the answer which actually was the correct answer in the exam could have been different from the answer that I'm telling you. But to the best of my ability, I'm trying to answer the questions that were asked in these exams, in this exam, the pediatric questions. So question number one was that stated a 9-month-old child admitted in ICU with history of recurrent sinusitis and otitis media. The infection was caused by Staphylococcus aureus. Decreased serum IgA, IgG, IgM, IgE. So immunoglobulin levels are all decreased. And they asked the question, what is the most likely condition that this child is suffering from? Now, to be very frank, this is a little question which is a little away from the pattern that you would normally expect in the Fmge exam. But anyway, since the question was asked in this exam, so we'll try to answer this question. So this very clearly indicates that there is a immunodeficiency that is occurring in the child. And immunodeficiencies can be antibody related immunodeficiencies, and this appears to be antibody related immunodeficiency in which nearly all the immunoglobulins are actually low. IgG is low, IgA is low, IgM is low. So this is a primary immunodeficiency that is seen in children. And this primary immunodeficiency seen in children is called as X-linked A gamma globulinemia. So what is the name? It is called as X-linked A gamma globulinemia. The other name for this condition is Bruton's A gamma globulinemia. So this condition is a primary immunodeficiency that is seen in children. It is in fact recognized as one of the most common primary immunodeficiencies that is seen in children, which is called as X-linked A gamma globulinemia, given that it is X-linked inherited disorder. So males or boys are only affected. Predominantly, it is the boys that are affected with this condition. So whenever a question related to this condition will be given in the exams, a very vital clue is that boys will be affected with this condition. Immunoglobulins invariably will all be low because ultimately the condition manifests as inability for the precursor B cells in the bone marrow to be able to form mature B cells. And that is why the antibodies are all reduced. And you are getting this clue where they have written decreased serum IgA, IgG, IgM. So this is a very important clue that all the immunoglobulins are low. Another clue that this is a Bruton's syndrome or Bruton's A gamma globulinemia is that the child has been having recurrent sinusitis and otitis media caused by Staphylococcus aureus. Please remember, this is a condition which manifests as recurrent infections caused by encapsulated bacteria such as Streptococcus pneumonia, Staphylococcus aureus, H. influenza. So recurrent infections starting from around 6 to 9 months of age. So when the child is around 6 to 9 months of age, the child starts having these recurrent infections caused by encapsulated bacteria. Entero infections are also very common in these children. So that is the second clue that this is a case of Bruton's A gamma globulinemia. Obviously, the child has to be lifelong on immunoglobulin therapies, and this is a condition which is not associated with a very good prognosis. Why this is not ataxia telangiectasia? Again, the ataxia telangiectasia condition is a condition that is known to be associated with ataxias, conjunctival telangiectasias. Then this condition is definitely not associated with decrease in the immunoglobulin levels. Chronic granulomatous disease again is a condition which is associated with immunodeficiency. That is basically a condition more associated with neutrophil phagocytic function defects. Also, a very important reason why this condition cannot be chronic granulomatosis disease is that since in chronic granulomatosis disease, the primary problem is a defect in the NADPH oxidase catalase, the neutrophil phagocyte function. So immunoglobulins are not affected. So immunoglobulins will either be normal or immunoglobulins will be high in those cases. But in our case, immunoglobulins are low. So that again goes in favor of Bruton's syndrome and goes against the diagnosis of chronic granulomatosis disease. There also there will be recurrent infections, recurrent bacterial infections, recurrent fungal infections in chronic granulomatosis disease. But there the immunoglobulin levels will either be normal or will be raised. Dijot syndrome, you all are aware of, is associated with hypocalcemias, thymus aplasias, congenital heart defects, which are not given in the question. So all in all, this appears to be clearly a case of X-linked A gamma globulinemia or Bruton's A gamma globulinemia. The second question again is a question where I did not get really very good options, and that is why whatever options were given, I was a little confused myself how to answer this question. The question that students have told me is that a neonate is delivered with the mother having gestational diabetes. The baby has dyspnea and the oxygen saturation is 8%. It actually was mentioned as 80%. Now, debatable point is that they have mentioned that 80% is the oxygen saturation at 4 days after birth. 80%. Now, please understand that in case the question is 80% is the oxygen saturation at 4 days after birth, this has nothing to do with neonatal resuscitation. Students often try to answer it as neonatal resuscitation. This is now no longer neonatal resuscitation, because neonatal resuscitation is the resuscitation at the time of birth, just after birth. So that concept of 21% oxygen in terms and 21 to 30% oxygen in preterms that I normally teach the students, room air in terms and 21 to 30% preterms, is applicable for a neonatal resuscitation. In case they have asked that on 4th day or 5th day after birth, the child has developed dyspnea, you have to treat this with oxygen. Again, I was not getting the correct options among the options given, which would make me believe that this should be the best answer. See, when we talk about newborns or neonates, the ideal thing to know is that just after birth, an ideal target saturation of a newborn, or the oxygen saturation that we expect in a newborn, say at 1 minute after birth, is never 100%. It is around 60%, the oxygen saturation. And this goes on increasing till 5 minutes after birth. This oxygen saturation goes up to around 80 to 85%. And after 5 minutes, say around 5 to 10 minutes, this oxygen saturation now becomes 85 to 95%. So what I'm trying to say is that you should never expect the oxygen saturation immediately after birth. So this is after birth. So you should never expect the oxygen saturation immediately after birth, say at 1 minute after birth, to be 100%. You expect 1 minute after birth, the oxygen saturation should be around 60 to 65%. By 2 minutes, it becomes 65 to 70%. 3 minutes, it increases to 70, 75%. 4 minutes, around 80%. And then by 5 minutes, it becomes 80 to 85%. So had this child been a child who was being seen at 4 minutes after birth, not 4 days, 4 minutes after birth, then a target oxygen saturation of 80% would be fine for me, because you expect this much. You expect this much. But in this case, if they have written 4 days after birth, then definitely I would like to treat it with 100% oxygen at 4 days after birth. Again, I'm saying in case it was 4 minutes after birth, the oxygen saturation that you expect at 4 minutes or 5 minutes after birth is around 80%. And therefore, if I'm getting an oxygen saturation of 80%, it was not 8%, it was 80%, then I would say wait and watch. It would be the best approach because this is what I want. After 5 minutes, say around 10 minutes, and then subsequently, the expected saturation of oxygen in newborns should be 85 to 90%. And thereafter, in all newborns, later on, we expect the oxygen saturation, target oxygen saturation to stay between 90 to 95%. So this is what we target in a newborn. 90 to 95% oxygen saturation. So we normally start giving oxygen in the newborns when the oxygen saturation starts dropping below 95%. And the target oxygen saturation that we will maintain in most newborns, especially in preterm newborns, will be 90 to 95%. So how much FiO2, how much concentration of oxygen I'm giving is not important. What is more important is what is the target oxygen saturation that I will maintain in a newborn. And the target oxygen saturation that I will maintain in a newborn is 90 to 95%. So we start with a low flow nasal cannula oxygen. And in case the child is not able to maintain target oxygen saturation, we increase the rate of oxygen to high flow nasal cannula oxygen, and then we may increase up further in case the child is not maintaining to CPAP, a non-invasive ventilation, and later on, if the child is in a respiratory failure, escalate to invasive ventilation. So that is how you escalate. But to be very frank, how much FiO2, how much concentration of oxygen I'm giving is not that important. The net important thing is what should be the target oxygen saturation I should achieve in the newborn, and that is 90 to 95%. So given on the 4th day, they are asking how much should be the oxygen to be given in a child, given that the child is in dyspnea 4 days, then I probably would say 100%. So again, I would still say that once I'm better equipped with what actually the options were, and whether it was 4 day or 4 minutes after birth, the question, then I would be better able to answer what is the correct answer to this question. But as of now, if it is 4 days after birth, I would say the best way to treat the newborn would be 100% oxygen. Give 100% oxygen. But again, what should be the target oxygen saturation newborns? 90 to 95%. You should not overshoot 95% target oxygen saturation, especially in preterms, because of the risk of problems that can occur in preterms, especially problems such as bronchopulmonary dysplasias and retinopathy of prematurities. So later on, if we get more options and the exact question, then we would probably be discussing this question once again at a later stage. Question number 3 says a newborn has microcephaly, intraparenchymal calcifications, and chorioretinitis. So this is a torch infection, and torch infections can be associated with intracranial calcifications. Now, the two most common type of intracranial calcifications that we get in children, torch infections. One can be intracerebral calcifications. Intracerebral calcifications, and the other can be periventricular calcifications. Periventricular calcifications. So when you have intracerebral calcification, as appears to be the case here, then the most likely cause of intracerebral calcification is congenital toxoplasmosis. But in case we have a question where they have mentioned periventricular calcification, chorioretinitis, periventricular calcifications, and microcephaly, then you should go in for a cytomegalovirus. So here they have mentioned a microcephaly, intraparenchymal calcifications, and chorioretinitis. Since they are mentioning intraparenchymal calcification, it obviously cannot be CMV, because CMV, as I said, is associated with periventricular calcification. Why it cannot be rubella? Because rubella has a different set of problems. Rubella, congenital rubella syndrome is associated with patent ductus arteriosus. Now, there were some students who were telling me the question was asked on congenital rubella syndrome also. So patent ductus arteriosus, congenital heart defects. The classical triad is congenital heart defects, cataracts, and sensorineural hearing loss. That's the classical triad for congenital rubella syndrome. But here we do not have sensorineural hearing loss. We do not have congenital heart defects. So I will not go in for rubella. Congenital varicella syndrome again is associated with limb atrophies. Then it is associated with brain atrophy, cerebral atrophies. It is associated with zigzag scarring on the skin, which is called as cicatricial scarrings on the skin. That is congenital varicella syndrome. So again, varicella cannot be the answer here. So the best answer to the question is toxoplasmosis. Congenital toxoplasmosis is the best answer to the question here. Question number 4. A 5-year-old child came to the casualty with fever and rash. So there is a child who has come to you with fever and rash. Upon eye examination, bite-root spots are seen. So this fever and rash most commonly appears to be measles, and there has been a good number of studies which have shown that measles is a disease or a infection in which vitamin A administration in the management strategy of measles can reduce morbidity and mortality. Obviously, in a child of measles, you have to isolate the child. So isolation is very important. Now, if isolation was also mentioned in the option as students were telling, then it is very good. So isolation, good nutritional supplementation, and vitamin A administration should be the best strategy to treat this child, because this child most likely has measles infection. Now, because the child has bite-root spots also, this bite-root spots indicates that there is a vitamin A deficiency in the child. Bite-root spots are actually foam-like lesions that are present over the bulbar conjunctiva. They are very commonly seen on the temporal side of the bulbar conjunctiva. So vitamin A deficiency is also present in this case, which makes me believe all the more that we should give this child vitamin A, nutritional supplements, and because the child has measles, obviously you have to isolate the child. Measles vaccine will not help this child because a measles vaccine is more for prevention rather than for administration as a part of treatment. And the third choice, institutional isolation and nutritional supplementation alone is not enough. Vitamin A administration is there. How much vitamin A administration helps in vitamin A deficiency? So in case there is a vitamin A deficiency, they normally say that a vitamin A administration of 50,000 units in children who are below 6 months, 1 lakh units in children who are between 6 months to 1 year, and 2 lakh units in children who are above 1 year would be very helpful. However, your ophtha faculty will be the best person to tell you the exact dose of vitamin A that is given in vitamin A deficiency. And why is the child having vitamin deficiency? Obviously, because the child has bite-root spots. You must be knowing that WHO classification of eye changes in vitamin A deficiency, which is X1A is conjunctival cirrhosis, X1B is bite-root spots. X2 is corneal cirrhosis, X3A is corneal ulcers covering less than 1/3 of the cornea, X3B is corneal ulcers covering more than 1/3 of the cornea, XS is corneal scarring, and XN is night blindness. So because this child has measles also and additionally has a vitamin A deficiency also, it makes sense in administering vitamin A along with nutritional supplements and isolation in the child. So according to me, for this question, 4A should be the correct answer. Coming to question number 5. Again, this question was out of the box, especially for FMG students. I would not expect such a question to be asked in the exams, but you always have 1 or 2 such questions that can be asked in the exams. The question was, a child with fused carpal bones comes to your clinic. What is the gene associated with this hand-feet syndrome? So this actually hand-feet syndrome is more appropriately called as the hand-feet genital syndrome. Or sometimes it is also mentioned as the hand-feet urogenital syndrome. Now, this is the disorder, as the name suggests, is a disorder which is associated with problems of the limbs, the hands and feet. Especially which problems are there? The most common problem, the hand and feet problem, the limb deformity that is seen in these cases is the shortness of the thumb and the shortness of the first toe. It is probably because of shortening or fusion of the distal metacarpals in the distal metatarsals. So short distal metacarpals and metatarsals are one of the most common reasons why these children have short thumb and short toes. So there are abnormalities of the limbs. Plus there is also abnormalities of the distal part of the urinary tract. So abnormalities related to urinary bladder, abnormality related to ureter are also part of the hand-feet genital syndrome. The cause is believed to be a mutation in a homeobox protein coding gene, which is also called as the HOXA13 gene. Now, this HOXA13 gene codes for a homeobox protein, which is associated with the development of the limbs and also associate particularly the distal part of the limbs, and also it is associated with the development of the urogenital tract. So this homeobox protein is coded by the HOXA13 gene, and HOXA13 gene mutation whenever it occurs. So obviously this protein is defective, which may be the result, which may result in the shortening of the distal part of the hands and feet. That means shortening of the metacarpals, shortening of the metatarsals, fusion, malformed limbs, and also malformed urinary tract. So this syndrome is called as hand-feet genital syndrome. They have said that the child has fused carpal bones, and had they also written about the urogenital tract being defective, it would have added to the answer or provided an additional clue to the answer, that the answer to this question is HOXA13 gene mutation, because this is a hand-feet genital syndrome. But definitely a question which I would not expect to be asked in Fmge exam. Now, question number 6 is a very simple question which I've answered many times in my classes also. A child with a mid-arm circumference of 105 millimeters. So when you are asked about a child who has a mid-arm circumference of 105 millimeters, 10.5 centimeters. Now, I have told mid-arm circumference is measured by Shakir's tape, and on Shakir's tape, a mid-arm circumference of more than 13.5 centimeters is considered as normal. A mid-arm circumference of more than 12.5 centimeter is considered as no malnutrition. A mid-arm circumference of 11.5 to 12.5 centimeter is considered as moderate malnutrition. And in case the mid-arm circumference is less than 11.5 centimeter, it is considered as severe malnutrition. Severe malnutrition. And therefore, our best answer should be a severe acute malnutrition. Now, since some students were saying that they had mentioned no danger signs were there, so this does not bring it into a complicated severe acute malnutrition category. So I would answer it as an uncomplicated severe acute malnutrition category, because the mid-arm circumference indicates that the child has severe malnutrition. Mid-arm circumference is less than 11.5 centimeter, and there does not appear to be any danger sign that is present in this child. Acute malnutritions, chronic malnutritions were the other choices that the students said, but this will not classically fit into an acute or chronic malnutrition. There are other markers to measure acute and chronic malnutrition. Mid-arm circumference less than 11.5 centimeter indicates severe malnutrition, and therefore the best answer to this question should be uncomplicated severe acute malnutrition. And I'm sure if students have gone through the classes, my classes, they would have 100% answered this question correctly. Coming to question number 7, chronic malnutrition is best measured. Again, I make the students revise again and again in my classes. When I'm doing growth and development, I again and again tell the students about weight for age, height for age, and weight for height. I make the students again and again understand the differences, and those students who have attended my classes in MIST have been should definitely be testimonial to this fact that I make them revise again and again. Acute malnutrition, how to measure, chronic malnutrition, how to measure using these markers. So weight for age is a very good marker for acute malnutrition, but gets affected in chronic malnutrition as well. Weight for height is the best marker for acute malnutrition. This is the best marker for acute malnutrition. Weight for age is a marker for acute malnutrition, but is also a marker for chronic malnutrition. But when it comes to height for age, this is purely a marker for chronic malnutrition. Stunting, chronic malnutrition or stunting can be indicated by height for age of the child getting affected. I'm sure students who have attended my class would be very clear about this answer. Chronic malnutrition is best measured by height for age. Acute malnutrition can be measured by weight for age also, weight for height also, although the best marker for acute malnutrition is weight for height. But when it comes to chronic malnutrition, there is no debate about the fact that the best marker for chronic malnutrition in children is height for age. So height for age, best marker for chronic malnutrition in children. Again, question number 8 is a question in which there was a lot of discrepancy as students were not able to narrate what exactly the question was and what the options were. So the question was, children easily get dehydrated. What is the difference between the extracellular fluid and intracellular fluid ratios in children in comparison to adults? See, the total body water is very high in the fetus. High as much as around 90% of the total body weight is water in the fetus. By the time the child is born at birth, almost 80 to 90% of the total body weight is body water. Then it goes on decreasing with age, and by the time the child reaches around 1 year of age, at 1 year of age, 60% of the body weight is water. So while at the neonatal period, say at the time of birth, almost 80 to 90% of the total body weight is water. This gradually starts reducing until the time is around the time the child is around 1 year of age. The total body water becomes 60% of the body weight, and after that it remains 60% of the body weight. Now, how does the extracellular fluid and intracellular fluid changes? So again, in a child at birth, it is the extracellular fluid which is much more than the intracellular fluid. So extracellular water is much higher than the intracellular water in the case of a newborn. Now, by the time the newborn turns into an infant and is around 3 months of age, the extracellular water now is decreasing, intracellular water is increasing. So by around 3 months of age, extracellular water becomes approximately equal to intracellular water. And then after 3 months of age, for the first time, the intracellular water becomes more than extracellular water. So again, they have mentioned children and they have not very clearly mentioned what age group. So conventionally below 3 months of age, if I say below 3 months of age, conventionally, I would say extracellular fluid is higher than the intracellular fluid in the child. By 3 months of age, extracellular fluid becomes equal to intracellular fluid. And after 3 months of age, intracellular fluid starts becoming more than the extracellular fluid. And by the time the child reaches 1 year of age, again the intracellular fluid and extracellular fluid ratio becomes what is the ratio that you see in adults. And then it remains the same ratio in adults. So extracellular fluid being much higher in comparison to intracellular fluid in comparison to adults, according to me, is the best answer here. Again, as I'm saying, I could not really understand what exactly were the wordings of the questions. Similarly, I have just gone through the options which students have told me. I've mentioned those options in the slides here. Later on, please feel free to send me the questions and the options in my group. I have a Telegram group also. You can post it there also. I've already posted in my Telegram group. I've requested the students to put in the questions. So once you get the questions, accurate questions and all the 4 options, you are please feel free to post those questions to me through any channel, maybe through MIST. I can get those questions. You can post them in the group, and we possibly at a later date, if you want, can have another session with all the questions there, with all 4 options of each questions there. So these are still early days. Again, I'm saying again, this is a disclaimer. I'm again saying again and again that if the answer, if the options will be different, if the questions will be differently framed in comparison to what I have understood from the students what the actual questions were, then the answer definitely will be different. So going by what questions I could understand from the students and what options I could understand, this is the best possible answer. Coming then to question number 9. Question number 9 says a 3-month-old child has a respiratory rate of 56 per minute. This is again, I have told these in my classes. So students who have attended my classes should have been able to answer this question again. A 3-month-old child has a respiratory rate of 56 per minute. There are no chest retractions, no danger signs. So as per the categorization of no pneumonia, pneumonia, and severe pneumonia or very severe disease. Now this is the classification which I have told in my classes. How do you classify only cough and cold, pneumonia, and severe pneumonia? Right? So when we say respiratory rate is high or chest indrawing is present, but there are no danger signs. The moment danger signs start coming in, the moment oxygen saturation becomes less than 90%, I was telling you oxygen saturation is very important. Oxygen saturation is less than 90%, or the moment there is stridor in an otherwise calm child, when we call it as a very severe disease, that is when we start saying either severe pneumonia or very severe pneumonia. So either danger signs are present. Danger signs I've already told in my classes are persistent vomitings, child unable to drink any water, the child having convulsions or having past history of convulsions. All those are danger signs. So if the child has danger signs, if the child has an oxygen saturation is fallen to less than 90%, which again is debatable, but some people say oxygen saturation is than 90%. And then if there is a severe, if there is a stridor in an otherwise calm child, then we say that this category is either severe pneumonia or a very severe disease. But in our case, in our question, there is nothing like this. No danger signs, no mention of oxygen saturation being low. So according to me, this definitely does not come under severe or very severe category of the disease. Now, is it cough and cold or is it pneumonia? So for cough and cold, the respiratory rate has to be normal. Now, what is the respiratory rate? 56 per minute. So I've told in my classes, a child till 2 months, a respiratory rate of more than 60 per minute is fast respiratory rate. For a child between 2 to 12 minutes, a respiratory rate of more than 50 per minute is fast respiratory rate. A child between 1 to 5 years, a respiratory rate of more than 40 per minute is a fast respiratory rate. Now this child is a 3-month-old child and a respiratory rate is 56 per minute. So a child who is more than 2 months, a respiratory rate of more than 50 per minute is definitely fast breathing. And if it is fast breathing, it cannot be plain cough and cold. It has to be pneumonia. So this is the case of a pneumonia, not a case of severe pneumonia, not a case of cough and cold, but a case of pneumonia, going by the fact that the child has fast breathing. Again, I'm saying that if students have attended my classes, they would have been able to answer this question. So again, a pretty simple question. Then this was a question in which students had told me that there was an X-ray where they had asked a question, a newborn with breathing difficulty, and there was an X-ray which had shown the presence of intestinal gas and intestines in the chest cavity, which clearly indicates that the child has a congenital diaphragmatic hernia. Now, congenital diaphragmatic hernias can either be Morgagni hernias, which again I have told in my classes, Morgagni hernias, or they can be Bogdalek hernias. I have told very, very clearly in my classes that Morgagni hernias are always posterolateral hernias. And they are usually always located on the left side. In contrast, Morgagni hernias are always anteriorly located hernias and they are usually on the right side. So in our case, it's a posterolateral hernia that is mentioned. Posterolateral hernia that is mentioned. And in case they have mentioned left side, apparently the X-ray that students told me, there was intestinal loops which was seen on the left side of the chest X-ray. which very clearly indicates that this is a Boctelic hernia. It is not a case of Morgagni hernia. Had it been a right-sided intestinal loops and they had mentioned that anterior defect in the diaphragm, then we would have mentioned that this is a case of a Morgagni hernia. But going by the question, it appears to be a case of Boctelic hernia. Treatment obviously should be immediately intubate the child, nasogastric tube insertion, ventilation followed by surgery, which is usually done by the second to third day, but can be individualized from case to case. Coming to question number 11, again, students say this was, different students telling different ways of this question. Apparently, the child with a short stature and the child's upper segment to lower segment ratio was mentioned. Again, if the students have attended the class, they should have been able to answer the question, whatever the question was. I've told that short statures in children can either be proportionate or disproportionate. I'm going by pathological short stitches. I'm not right now talking about physiological short stitches. So pathological short stitches can be proportionate, disproportionate. Since the upper segment to lower segment ratio is high here, or it may be low, it is definitely a case of disproportionate short stitches, not a case of proportionate short stitches. Now, disproportionate short stitches can be of two types. It can be either a long trunk dwarfism, which is also called as infantile dwarfism, or it can be a short trunk long limb dwarfism, which is also called as advanced dwarfism. So based upon the upper segment to the lower segment ratio. So if the expected upper segment to lower segment ratio is more than what is expected, we call it as a long trunk dwarfism. And I've told infantile dwarfism, the causes are congenital hypothyroidism, achondroplasia, and rickets. Now here they said the child has high upper segment to lower segment ratio. According to me, a high upper segment to lower segment ratio should be infantile disproportion, infantile dwarfism. And in such cases, congenital hypothyroidism, achondroplasia, rickets, all will come in this category. Some students said, sir, they had mentioned except, which makes sense to me, because when they say except, all of them are cases of infantile disproportion except, then it makes sense that if it is except, then the answer should be a spondyloepiphyseal dysplasia, because spondyloepiphyseal dysplasia is long limb or short trunk dwarfism. It is also called as advanced disproportion. So it is also called as advanced disproportion. So here the upper segment to lower segment ratio will not be more, but will be less than expected. So in case the upper segment to lower segment ratio is more than expected, that means the trunk is longer than expected. So in those cases, I would think of congenital hypothyroidism, rickets, and achondroplasia. So in case they mention all except, then spondyloepiphyseal dysplasia definitely will be the correct answer, because this does not present with long trunk but present with short trunk and long limb dwarfism or advanced disproportion. Again, based upon what the question was, what the options was, you could have different answers, but I'm just telling you that if you have attended the class, no matter what the, so all in all, this was according to me not a very difficult pediatric recall session. Not a very difficult pediatric FMG part session. If you have attended the classes, except for one or two or maybe three questions which are out of the box, other was standard, pretty standard and pretty straightforward questions which you should have been able to answer. If you will provide me all these questions with proper options at a later date, I would love to have a separate session in which I would again discuss all these questions and the answers to these questions to the best of my ability. So with this, thank you from Team MIST. I'm Dr. Pankaj Tikku signing off. I hope you have understood, at least superficially, you have understood what the answers to the questions were the pediatric questions. And I hope most of the pediatric questions have been successfully answered by you. So with this, I say goodbye, and we'll meet again in one of our classes in the new session for those who will be joining the new session. Those who are not joining and have obviously cleared, very good. Best of luck for your NEET PG preparations. So thank you, all the best, and goodbye.